Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome back to The View on GU. For my co-host Ali Khan Lalani, I'm Chris Wallis, and I'm happy to see that you've joined us for our third episode here from Barcelona, covering the latest and greatest coming out of ESMO 2024. We're now on our kidney cancer coverage. We've gone through prostate and bladder, so if you missed those episodes, circle back and hit those ones up after you're done hearing all about the progress we've made in kidney cancer this year. So, I think this year was a little light on kidney cancer compared to some historical years at ESMO. I think when we think over the last 3 years or so, we saw really transformational data often presented at ESMO that has established an IO backbone doublet as our standard of care for metastatic kidney cancer. So we have obviously the original Nivo-Ipi data and then a variety of IO-TKI combinations that have become the standard of care. And when we're using two mechanisms of action in our initial frontline therapy, the obvious question becomes, what do we do next? We've had a long history of mTOR inhibitors in kidney cancer, but we're looking for ways to make progress, ways to do things better. And so in that IO pre-treated patient, whether that's an IO-TKI doublet or doublet IO like a Nivo-Ipi regime, we really are looking for opportunities to do better when these patients progress. And I think right out of the gates, we saw T-Nivo2 presented by Tony Schwery, published in the Lancet as a major paper as well. Maybe you want to walk us through the data and
Sure.
I think it's got broader implications maybe than just the cohort that was accrued.
Yeah, I agree. And I think it's on the heels of another CONTACT trial looking at cabozantinib for patients who have progressed on IO, and then looking at atezo-cabo, a PD-L1 inhibitor after a prior IO. This was a negative trial. So we had a press release about T-Nivo2, but really got to see Tony present on this patient population that progressed on one or two lines of therapy, one of which had to be an immunotherapy, but didn't have to be the immediate agent prior. And so really these patients who, again, have had pretreated RCC stratified by IMDC risk group, and whether the immunotherapy that they had before was immediately before or perhaps a line before that. And these patients then got randomized 1-to-1 between tivozanib, which is a TKI that has some approvals around the world in a pretreated or a first-line setting. The control arm got 1.34 milligrams of oral dosed tivozanib. And that's important because the intervention arm was given nivolumab with 0.89 milligrams of tivozanib, largely FDA-driven based on hypertension to try and have a lower dose in the combination arm. And then this trial had a primary endpoint of PFS with the usual secondary endpoints, a very standard pretreated kidney cancer, median age around 65, mostly male, good ECOG performance status, nice balance of IMDC risk groups, just under 20% favorable, under 20% poor, the rest all intermediate. 2/3 had one prior line. And importantly, 70% of patients had ICI as the most recent therapy prior to coming on trial, but 30% had a non-ICI regimen, and there were patients, 30%, who had no prior TKI, meaning they would have had some sort of an IO-IO or IO alone, largely IO-IO first-line treatment. But really, takeaway is median PFS, which was, again, and has been a registration endpoint in RCC, but for this study was 5.7 months actually for the intervention arm of the combination, and up to 7.4 months with tivozanib, admittedly higher dose, but that led to a hazard ratio of 1.10. A lot of predefined analysis that point estimates all are at unity. And, really the median OS was, again, in the combination, 17.7 months and up to 22 months in the monotherapy arm. So, really, when we look at other endpoints like objective response around 1 in 5 for really both agents, primary PD rate of, really I would say 29% really in both arms. And so, I think at the time that both trials were designed and conducted, there was a question about what do we do after you've had a prior IO. I think we know now the big takeaway. And in some jurisdictions, we're quite lucky that kind of health agencies or jurisdictional approvals will guide. But in situations where maybe it was a Wild West or where there wasn't such strict guardrails, I think this will change practice for some people to say receiving an immunotherapy agent after another immunotherapy agent is not recommended in a metastatic setting. Many of us, Canada or other countries where it's a little bit more rigid about how you can use these agents, we're never really using IO after IO in mRCC. But it does beg the question about what we do adjuvantly and what we do then thereafter. I would just make a quick point before we get to that, Chris, that some postulation made on the dosing of TKIs. I totally agree. TKIs need to be appropriately dosed. We see if you underdose or don't do drug and schedule individualization, you don't optimize care for patients. But it's unlikely with these hazard ratios that a slightly higher dose would completely obviate and change the trend in the other direction. Mm-hmm. But let's kind of make this more broadly for our listeners and viewers. I think we've settled the science on IO after IO, at least with the current era of checkpoint inhibitors. The question becomes, after you received adjuvant immunotherapy, could immunotherapy be used? Maybe before we even get to that, refresh us as to how things have gone since earlier this year. We talked about adjuvant RCC for you in your practice as urologist. Let's dovetail there. What is this practice of even getting adjuvant IO really like, and that referral pattern from a urologist perspective?
Yeah, I think it's important to put it in context. Obviously, it's been a few years since we first saw the data from Keynote 564. We saw originally the DFS benefit, and then we've seen since that time OS data. So obviously that OS data readout was pretty monumental part of GU ASCO this past year. And we've talked about it a lot at that time. The New England Journal paper came shortly thereafter. And so just to refresh things, we've got adjuvant pembrolizumab in intermediate high or high risk localized or M1 NED fully resected patients. So for the average urologist, this is your T3s, your T4s, your node positive. There's a subset of T2 in there with sarcomatoid or grade 4. But for the most part, these are going to be your T3 and T4 patients or node positives. And we see OS benefits. And so importantly, that's like a hazard ratio of 0.62, 38% improvement in overall survival. And so to me, those data are compelling. And I think this means that urologists can't and shouldn't be gatekeepers in this space. We need to be initiating referrals. We need to be involving our medical oncology colleagues in this patient population that used to be historically just in our clinics. They were just getting follow-up according to CUA protocols or your local institutional protocols. But these are patients who really benefit from, at minimum, a conversation about the pros and cons and trade-offs around the use of adjuvant therapy. I think we're seeing that there are local and regional patterns emerging, and it's not always so clear that these patients are getting access to those discussions, let alone the therapy. And so, I think, before we, put the cart ahead of the horse, we need to make sure that these discussions are being had, patients are being offered IO. And then obviously we circle back to then, as you were alluding to, what we do for those patients who have received adjuvant IO, adjuvant pembrolizumab, and when some subset of them progresses, how we manage them.
Yeah, no, it's a great point. I think just at least from a local perspective in Canada and other jurisdictions, we do have the at least preset guidance that once you complete adjuvant IO, if your cancer or patient's cancer were to come back more than 6 months after completion, the clock resets. So at least we have some general guardrail as to when immunotherapy from an adjuvant setting would be used in a metastatic setting. Obviously, what's unknown is how active it will be. So for those patients on surveillance who received adjuvant therapy, I think we do have more focal options available. SBRT use is rising. And so again, I think it really does reinforce that these patients need to be referred in a way Each group might have different practices. We've recommended that those who are eligible get referred. We give the patient kind of the what they deserve, which is the respect and dignity of having a conversation around a reimbursed available option that is now shown to improve OS. And whether the patients choose that or not is a part of their shared decision making. But we have not been, as you say, restricting the conversation. But it still asks about whether that immunotherapy agent will work quite as well in the metastatic setting. And hopefully the longer time between completion of adjuvant and use in metastatic will be one helpful clinical time point to see. But this is where real world data will be very helpful.
Absolutely. Totally agree. And I think, this discussion has really highlighted, the opportunities or the gap that remains to be filled to try and find, novel mechanism of action when we're worried about whether we can sequence similar mechanism of action. Obviously, the logic is to try and find a novel mechanism of action. So, in the context of clear cell renal cell carcinoma, you always want to go down the VHL pathway. So maybe you want to walk us through LightSpark 005 and the role of belzutifan in these patients.
Yeah, highly anticipated, published in the New England Journal. Again, this was a trial, randomized 1-to-1 trial of taking patients who had been treated with clear cell RCC, having anywhere between 1 and 3 prior systemic options. At least one had to be immune therapy and one had to be VEGF TKI, randomized to belzutifan at a dose of 120 milligrams daily versus everolimus. We'd seen previous data on PFS, and this was also shown again. The medians between the two arms were similar, but when you follow the totality of the curve, median is not enough. That hazard ratio is 0.75. So positive study in terms of heavily pretreated patients to have an option available that I think beats a historic, and admittedly not current, but beats a historic standard of care in terms of everolimus. Now, what we were waiting for was to see OS, and with just under 70% of events in both arms, the median was numerically 18 months in everolimus, 21 months in belzutifan, but that only related to a hazard ratio of 0.92. Still lots of censoring after 27 months, but at 2 years, that looks like an improvement of about 4% in overall survival. But again, not a slam dunk of a significantly improved OS in this context. Response rate, though, does tell you about clearly some patients are benefiting. It's not just a statistical artifact in terms of OS not being significant. I mean, response rates of 22% in this pretreated setting, countered by the fact that patients in everolimus or belzutifan, 1 in 4 or 1 in 3 will have primary PD. And that's what we see in clinic in heavily pretreated population. So one of the things we are observing is that time to response, although both around 4 months in either arm, has a much wider range with belzutifan, meaning those patients who might get some interval shrinkage or perhaps still stable disease might later have a response to the kind of slow effect of it. So notwithstanding attrition in both arms, I think when you use this drug, it may not be that first scan that's perfect. But this will be a complicated review, I think, at HTAs or other jurisdictions for review, because I think one could suggest that there's an unmet need criteria here, depending on how each country does it. The medians aren't as sexy, but the totality of a hazard ratio for at least for PFS, there is some benefit. And then again, in the context that this isn't first line treatment, this is heavily pretreated. So, should and could this be available? To your point, right? We're not going to recycle immune therapy for metastatic disease. Could we add a novel mechanism? And then realizing again, the story is not sold on belzutifan fully. We're going to be looking at trials in a post-frontline with lenvatinib against cabo, and then again in a first-line setting. So there's more to come, but this was important data to see the full or near complete OS readout.
Mm-hmm. Yeah, I think this data gets us through to real discussions about registration decisions.
Mm-hmm.
And I think we've gone probably the most direct in the RCC pathway with VHL conversations. Mm-hmm. And maybe that gives us an opportunity to pivot away from the clear cell discussions. And I think the last major trial that's worth us talking about was SUNNIFORECAST. And I think this is obviously an interesting patient population. The non-clear cell, it's a heterogeneous group. There's a whole bunch of different histologies. But maybe give us your take on the role of nivo-ipi in this patient population.
Yeah, it's great. The SUNNIFORECAST trial, very quickly, as you mentioned, a full slate of non-clear cell RCC patients, or what some folks might call RCC of variant histology, a first-line study, randomized to standard of care agent at the time, or nivo-ipi as we've generally been giving it. Key thing is they've had a median follow-up of almost 2 years. They have a primary endpoint of OS rate at 12 months. And one of the things we wanted to see is kind of what population was included. And so, just looking at some of that top line data from the 309 patients, about 150 in each of these arms, there's a good smattering, about 57% papillary, 20% chromophobe, a renal medullary, which in general we do see, and I personally feel is much more chemosensitive. It's not ideal to be giving IOs or TKIs to RMC patients. But these were really just 3 patients. There's translocation, again, a whole slew of other patient populations. I mean, at the back of the room, I think it was important to see that nivo-ipi is clearly active in some of these patients. This is a good combination regimen. OS rate at 12 months was 87% for nivo-ipi, 76%, just under 77% for the standard of care. Now, that met the statistical predefined endpoint. The standard of care will vary because some patients would have had a TKI mono. And already there was a tease from presenter about SUNNIFORECAST 2, which will probably be more defined in terms of the control arm. But I think what, the real takeaway here is that there are patients that benefit from doublet IO. I think even the discussants and the presenters say that historically we've been selecting IO TKIs for these patients, notwithstanding those who really should be getting chemotherapy as their first-line option. But one interesting thing I took away was that PD-L1 positivity seemed to be a big discriminant. The negative versus positive had, 1.4 hazard ratio versus 0.5. I mean, really ends of the forest plot estimates. And I kind of thought we graduated from looking at PD-L1 in RCC. So there's probably something to unpack there. Mm-hmm. And then as folks look at that deeply, the response rates, I think, are quite different. And so seeing where papillary response rates are kind of well known, but seeing even chromophobe having a nivo-ipi response rate of even 26%, those are usually ones that we feel are more TKI and mTOR sensitive. So being able to add a line of therapy perhaps needs further assessment. But I would say that as you asked for that zoom out, Chris, that many jurisdictions have not restricted nivo-ipi to just clear cell. We're fortunate in Canada, many other countries as well, that have it for advanced RCC. So this helps us understand there may be that patient population that could get a doublet IO. I think really the inertia needs to be there, that we won't have large phase 3 trials for all of non-clear cell. So I'll just make one point to say that I think we need more histology bespoke trials. We have more molecular drivers known in RCC of this variant histology. And so we're probably going to need smaller phase 2, maybe even single arm. That will be tougher to review at jurisdictional levels, but I think that's important. And then the second piece is we need more guidance. And I think we're going to be having, at least from the Canadian Kidney Cancer Forum, a shout out to the consensus document that should be coming on how to manage patients with variant histology. So that really tries, because I do know from a urologist angle, even when you're cutting out and resecting a so-called non-clear cell, you might have a different biological behavior that you observe in a resected setting versus what we see pre-treated or even first-line non-clear cell.
Yeah, absolutely. And I think that was one of the takeaways for me, not someone who gives these drugs, but the heterogeneity we saw within this non-clear cell population. And really, it appeared that the papillary subset, from my takeaway, got that benefit in the TKI angle, their so-called standard of care. Probably that's a doublet today, but it really seemed to have differential effects based on the histology, and really highlights your point that this is not one disease space. We need much more work done in probably smaller cohorts to understand the optimal way to treat these patients.
Yeah, absolutely. And I guess just to a final potpourri, just to give a little plug for some work, first line setting, not clinical outcome, biomarker outcome analysis from Checkmate 9ER, which a friend and colleague, David Braun, presented, looking at glycoproteomic biomarkers that might predict response. So looking at prognostically, depending on glycosylation or other type of features that happen found on blood tests or tissue using AI. We might be able to source out those folks who are prognostically going to behave a certain way or might predict better the combination or mono TKI treatment. I guess the real takeaway from that is that we've had all these frontline trials have biomarkers emerge, kind of programmatic themes in that trial. And then when you've tried to copy paste or extract to others, it has not borne out. And then obviously when you're looking at outcomes or biomarker signals from Nivo, for example, here in Cabo, trying to understand contribute parts from Nivo and Cabo, there are monotherapy trials that you could extrapolate this from. So I just think it's part of a larger theme of biomarkers and perhaps more blood in certainly prostate and bladder are ahead of the game, but I think in kidney trying to work on that, both in a resected and an advanced setting, it behooves all of us who are interested to try and make our institutions able to do some of this work, at least some of it. And not every place is going to have a silo of excellence, but to try and be on the same page for that so we can do this in the future together going forward.
Yeah, I totally agree. I think that's probably a wrap on kidney cancer from ESMO this year. I want to thank everyone for joining us, and I hope the data has been interesting and valuable for you guys. If you've missed out on bladder or prostate, go back and catch those episodes. And in the meantime, on behalf of my co-host, Ali Khan Lalani, I want to thank you for joining us, and don't forget to rate, review, and subscribe.